Hello everyone. Today we'll discuss about twin-to-twin transfusion syndrome. Okay. This twin-to-twin transfusion syndrome, it occurs due to the placental vascular anastomosis and unequal placental sharing. Okay. This vascular anastomosis, we'll talk about this. This vascular anastomosis includes, or it can be, a superficial one and a deep vascular anastomosis. This superficial vascular anastomosis includes arterial to arterial, and venous to venous. This is mostly of bidirectional flow. Which one? This superficial anastomosis. So the superficial vascular anastomosis, it can be arterial to arterial, venous to venous, and these are mostly having a bidirectional flow. While that of a deep vascular anastomosis, they include artery to vein anastomosis, and these are mostly a unidirectional flow. These are located in the placental cotyledons that are supplied by one fetus and are drained by the another fetus. So this anastomosis is located in the placental cotyledons so that are supplied by one fetus and the drained by another one. Okay, so this unidirectional flow or unidirectional twin-to-twin transfusion syndrome manifest anytime. These can manifest anytime after 16 weeks of gestation. They can manifest after 16 weeks. Okay. So these occur when the high pressure system joins with the low pressure system. So when the high pressure system joins with the low pressure system, this unidirectional flow occurs. So this is about the vascular anastomosis. Next we'll talk about the donor twin and the recipient twin. So one fetus is donor that slowly pumps the blood into the co-twin circulation, that is the recipient twin. So one fetus is donor. This slowly pumps the blood into the co-twin circulation due to the vascular anastomosis and the difference in the pressure. This is the recipient twin. Okay, so what are the complications that will be faced by the donor twin due to the flowing of blood from this donor to a recipient twin? So complications in the donor twin. So complications in the donor twin includes hypovolemia, and next is anemia, third growth restriction, fourth is oligohydramnios, due to the reduced perfusion, due to decreased perfusion, the child can have, or he or she will be at the risk of, the fetus will be at the risk of tissue ischemia and acidosis. Okay, supposing if this oligohydramnios in this donor twin is severe, okay, if the oligohydramnios is severe, it will lead to stuck twin. So what is called stuck twin? We'll see it here. So when this oligohydramnios is severe, it leads to what is called as stuck twin. Okay, so this twin will be, when this oligohydramnios is severe, this donor twin will be compressed against the uterine wall and it will suffer all the complications of prolonged compression. So this twin will be compressed against the uterine wall and it will suffer all the complications of the prolonged compressions. So due to prolonged compressions, what are the complications can be present? So these includes, prolonged compression. So these complications include, first, they can have pulmonary hypoplasia. Second, they can have abnormal phases. Third, they can have limb abnormalities or limb hypoplasia can be present. So these are the complications due to prolonged compressions, that is due to severe oligohydramnios. Next we will see the complications of recipient twin. Next is the complications of the recipient twin. So the complications in recipient twin, these include, since it is the it will receive all the blood from this donor twin, the child will be polycythemic, hypervolemic, third, there can be polyhydramnios, due to increase in the volume overload, that is hyperolemia, the child will go on for cardiac failure. Finally, it will present as fetal hydramnios in severe stages. Okay. So this is the complications of donor twin and the recipient twin. Next we will see its diagnosis. So the diagnosis is being made between 16 weeks to 26 weeks of gestation. So these are usually made between 16 weeks to 26 weeks. Okay. So what are the diagnostic criteria for telling that the child is having twin-to-twin transfusion syndrome? So diagnostic criteria, so you will be you have been read in this UG times that there will be a discordance in the weight of more than 20% and a HB of more than 5 gram per deciliter difference between these two between the twins. So this is not now mostly used because this is after the delivery. You have to find in the antenatal period. So when you find it in the antenatal period only, you can do some treatment for this twin-to-twin transfusion syndrome and you can reduce this rate. So first diagnostic criteria is monochorionicity, second, when you find a polyhydramnios in the sac of one twin, and oligohydramnios in sac of another twin, this itself will be more than enough to diagnose a twin-to-twin transfusion syndrome. Okay. Third can be umbilical cord size discrepancy. So umbilical cord size discrepancy. Fourth, there will be an abnormal umbilical artery or ductus venosus Doppler velocimetry. So you should do a Doppler to tell this. There will be an abnormal umbilical artery and a ductus venosus Doppler velocimetry. And as usual, in the postnatal period, you can find a significant weight discordance of more than 20%. This can be detected even antenatally using our ultrasound, this weight detection. But the main criteria for this to tell the patient is having a twin-to-twin transfusion syndrome is by seeing these two, that is polyhydramnios in one sac and oligohydramnios in the other sac, and the Doppler, that is abnormal umbilical artery and the ductus venosus Doppler velocimetry. Okay, this is about the diagnosis and the diagnostic criteria for twin-to-twin transfusion syndrome. Next, we will see the staging for this. The staging system is used to classify the severity. So the staging is used to classify the severity. So the staging used in the twin-to-twin transfusion syndrome is Quintero staging. Okay, so in Quintero staging there are 5 stages in this, starting with the stage 1. Here there will be oligo with the deepest vertical pocket. This deepest vertical pocket in the donor twin or the donor sac will be less than 2 cm. So the deepest vertical pocket will be less than 2 cm in the donor sac, and polyhydramnios with the deepest vertical pocket will be more than 8 cm in the recipient sac. This is stage 1. Next, stage 2, there will be the bladder of the donor twin will not be visible. So bladder of the donor twin will not be visible. In stage 3, there will be a Doppler studies are abnormal in either the donor or the recipient twin. Here the Doppler. So there will be a Doppler studies abnormalities in either the donor or the recipient twin. In stage 4, hydrops will be present, usually in the recipient twin. In stage 5, there will be a one or both the babies or both the twins have been died. One or both the babies have died. This is not amenable to the treatment. Okay. So first is oligo and polyhydramnios. Second stage is the bladder of the donor twin will not be visible. Third stage, the Doppler abnormalities. In fourth stage, hydrops in the recipient twin. In the fifth stage, one or both of the twin babies have been died. we will see the treatment for this twin-to-twin transfusion syndrome. Treatment will be the fetal treatment. Here we will have fetal treatment. This fetal treatment will be depend upon the gestational age and stage at the time of this twin-to-twin transfusion syndrome has been diagnosed or been identified. So this will depend on the gestational age and stage at the time of twin-to-twin transfusion syndrome is identified. Okay. In stage 1, it is mostly a conservative treatment. It is managed expectantly, as some will stabilize or it will regress. Okay. So as they will stabilize or regress. While from stage 2 to stage 4 twin-to-twin transfusion syndrome, when they are less than 26 weeks of gestation, you have to do a fetoscopic laser photocoagulation. Fetoscopic laser photocoagulation of these anastomosis. Okay, so this is the treatment of choice. It is fetoscopic laser photocoagulation of this placental anastomosis when the twin-to-twin transfusion syndrome stage is between 2 to 4 and they are less than 26 weeks of gestation. This is about the fetal treatment. Next we will see about the neonatal management. Neonatal management starts from the delivery room itself, starting with the resuscitation, at birth. Second, you have to do a IV access for the volume expansion if the child is hypovolemic to the treatment of hypovolemia. It is in a donor twin, and a PRBC transfusion to treat the anemia in this donor twin, and correction of hypoglycemia. Next, you have to do a partial exchange transfusion in a recipient twin to treat the polycythemia. So partial exchange transfusion is done in the recipient twin to treat polycythemia. Okay, so this is about the twin-to-twin transfusion syndrome in a shorter form. Okay, thank you. Next we will see about genetic counseling. I have posted the topics that we are going to discuss in the Telegram group. So next we will discuss about genetic counseling. Next is anti-epileptics part 2. There will be tumors. Okay, if you want any topic in between, kindly suggest me in the comment section or in our Telegram group. So the Telegram group is Peds University Nation Discussion Group. Okay, kindly you can post the topics that you needed in group or in the comment section also. Thank you.